Hello everyone. Assalamu alaikum wa rahmatullah. Today we will discuss a very important topic and it will be a quick video for the revision before the exam. What about the management of tubal ectopic pregnancy? Ectopic pregnancy, very, very important in part 3 exam. It was for a while high repeated station, so you can see the ectopic pregnancy in every exam. So we need to know how to manage and different options and what about the scenarios in the exam. So for the exam scenarios, we do have 4 exam scenarios regarding this topic, the tubal ectopic pregnancy, either to be ectopic pregnancy for first time or to be recurrent ectopic. And for both of them, it can be the patient can be treated with medical or surgical, or the surgery will be the only option suitable, and for the recurrent as well. So that's why we have 4 scenarios. So it can be first time and medical treatment is a suitable option. First time surgery only will be the suitable option. It can be recurrent with medical option suitable, or recurrent and only the surgery will be the suitable option. That's why we need to read the case notes very carefully to know what about the criteria we need to search about, or we need to find in this patient so we can offer the patient medical treatment. To explain this to the patient, what about the options and how we can choose the option, or what about the suitable option for her, it will depend on many things or many points. How many weeks pregnant you are, your symptoms and the clinical condition, the patient stable or not stable, she's vitally stable or not, she's in pain or not, the level of the beta HCG, the scan result, and it's very important to check the fetal cardiac pulsations and also the size of the sac, very important. Your fertility status and fertility wishes, your general health, and by the end, your personal preferences. So don't forget to involve the patient to see what about her preferences. For the options, you have to tell the patient about the 3 options, even if only the surgery will be the suitable one. But you have to say, we do have 3 options, wait and see, which is the conservative, medical treatment, and surgery. And if we have like wait and see, it's not suitable, just say we do have 3 options, wait and see, and I'm so sorry, it's not suitable in your condition. Because, for example, the hormone or the pregnancy hormone level in your blood is beyond the level, which is, it has to be less than or equal 1,500 or less than 1,500. For the medical, if it's not suitable, just touch this point and go. So the medical, and I'm so sorry, it's not suitable in your condition as well, then the surgery. Come to each point, I will explain the 3 options. So if it's in the exam, the medical is suitable, so you can discuss the medical treatment with the patient. We do have many safety points here with the methotrexate. Wait and see, or the conservative management, usually it's not an exam scenario. So usually you will not find the patient who can be treated with wait and see or the conservative management. But if we will have it in the future, so here is the expectant management or the conservative management, which we can name in layman language tubal miscarriage. So the miscarriage can happen from the tube itself by its own or on its own. Okay, it's similar to the miscarriage if the pregnancy inside the womb. We need to monitor the beta HCG levels for few days until it's negative. So here we need to follow up this patient. Don't discharge the patient back to home without giving her the red flag signs like feeling unwell, severe pain, severe bleeding, dizziness, loss of consciousness, anything like that. Success rate, it's around 30 to 100%. So this is the expectant or the conservative management. Medical treatment, it will be by a medication named methotrexate. We will give it to you by injection. It's intramuscular injection. The dose will depend on the surface area. So it's not, don't mention this in the exam because it will be a little bit complicated. Just tell the patient that we will calculate the suitable dose for you. And most of the ladies will respond from the first injection. However, we do have 15 out of 100 will need a second dose. 7 out of 100 will need a surgery. So we need to highlight this point to the patient. Patient safety points here: no pregnancy for 3 months. You have to tell the patient if the medical treatment is suitable and we will give you the injection. So we need to offer you a reliable contraception for 3 months because it's not a baby-friendly medication. And before injection, we need to see how's your liver work and also how's your kidney work. So safety points, very important, okay? And you need also to tell the patient that in the first few days after the injection, you may experience some pain or discomfort, but it will be well controlled with the simple painkillers like paracetamol or ibuprofen. And don't forget to give the patient, again here, the red flag signs like the conservative, because we will admit this patient overnight in the hospital and you will discharge her on the next day. So when you will discharge her back home, just tell her, if you have any pain, bleeding, dizziness, loss of consciousness, feeling unwell, so please come immediately to the emergency department. We need to admit the patient. As I told you, it will be overnight admission. Offer her the blood test and then offer her the injection. Some side effects of the methotrexate: now you will give a medication. You need to mention the side effects: pain, tummy upset, blurring of the vision, abnormal mouth taste. Treatment of the ectopic with methotrexate is not known to affect the capacity of the ovaries to produce eggs. Very important question from the role player, because she will be afraid this medication will affect my fertility or not. So stay in the hospital overnight, give her the red flag signs before discharge, give her the follow-up appointments. Now we will follow up this patient with the beta-HCG on day 4, day 7, and then after that it will be weekly. On day 4 and 7, we may find that beta-HCG is a little bit or slightly increased because of the effect of the methotrexate on the pregnancy or the gestational sac. Disruption of this sac will lead to temporary increase in the beta-HCG. After that, it will start to decrease. But if we have it like constant or stable or increasing, so at that time we may need a second dose or the surgery after 4 day and day 7. We will measure it weekly until it's less than 15 or until it's negative. This point here in the red color, to wait 3 months after the injection and avoid the pregnancy because it's a teratogenic medication. In the layman language, you will tell the patient it's not a baby-friendly medication. For the surgery, now we are done with the medication, with the medical management. Come to the surgery. We do have 2 options for that, either salpingectomy or salpingotomy. Before giving the 2 options here, you can also tell the patient we do have 2 ways to have the surgery, either to have a keyhole surgery, which we named the laparoscopy, or the open surgery. So the keyhole surgery will be through 3 openings or 3 small openings in your tummy, and a camera will be introduced inside your tummy to remove the pregnancy only or the pregnancy with the tube itself. The open surgery, it will be a small cut in the bikini line. And that's it. This is how to explain in a layman language. Coming to the 2 options, either salpingectomy or salpingotomy. If it's first time ectopic, so it's first time, so for sure it will be salpingectomy, removal of the pregnancy and the tube, or the tube with the pregnancy inside. No need for follow-up after salpingectomy because we remove everything. And the patient, if the patient will be pregnant next time, so she has to inform or just to tell her GP or the midwife immediately to offer her another or like early scan in the future pregnancy to check if we have any other ectopic pregnancy, because the risk of ectopic pregnancy will increase if the patient has 1 time ectopic, so the risk will be higher next time. If she has 2 times, so the risk will be higher. If the patient has recurrent ectopic and it's a very or highly repeated exam scenario to have 2 ectopics before, 1 treated with the medication, 1 treated with the salpingectomy, so she has now only 1 tube. So what to do at that time? Don't tell her it will be the salpingotomy because we don't know what's inside. This tube is healthy, not ruptured, no scar tissue around it, no bleeding. So at that time, yes, we can offer her salpingotomy. So just leave it to the consultant. So just tell her, we will offer you this keyhole surgery, and the consultant will see, what about your tube? Is it healthy? There is no scar tissue around it. It's not ruptured, no bleeding inside your tummy or lower tummy. At that time, we will open the tube, taking the pregnancy tissue out, and we will leave the tube without closing, or we will close with a tiny repair. If we find anything like scar tissue around it, or it's not healthy, or it's ruptured, at that time we need to remove the tube because it will be site of ectopic again. So highlight this point to the patient and reassure her directly by saying, don't worry, we still have options to be a mom by offering you test tube baby. So reassure her because it will be a shock for this mother or this patient. If you will offer her salpingectomy, no need for follow-up. The salpingotomy, we need to offer her a follow-up with the beta-HCG, and she may need injection after the salpingotomy or salpingostomy. You can pronounce it in both ways, no problem. Both are correct. And give her the side effects of the surgery generally, like salpingectomy or salpingotomy, it's a surgery. So there is risk of infection, bruises, bleeding, injury of any organ inside your tummy and lower tummy. If you have time and it's only this station, for example, recurrent or first time, and the surgery, the only suitable option, I will give you the criteria now for the medical treatment. If it's not there, so it has to be surgery. So if you have time, just tell her about the laparoscopy. What about the hospital stay? It will be around 24 to 36 hours. Usually the recovery will take from 2 to 4 weeks. If it's open surgery, the patient will stay in hospital 2 to 4 days, and the recovery will have the recovery in or within 4 to 6 weeks. One more thing in the salpingotomy or salpingostomy, especially, it will carry more risk. I told you, if you will tell or if the patient will have only the surgery suitable option, you have to give her the side effects of the surgery, the common line: infection, bruises, bleeding, injury of any structure in your tummy or lower tummy. Plus here in the salpingotomy, you have to add more risk, like risk of future ectopic pregnancy in the same tube. We need to offer follow-up for this patient. It's not complication of the surgery, but it will bother the patient to have repeated follow-up by measuring the beta-HCG. It has to be weekly until it's negative. And some ladies or women will need a further medical management after salpingotomy or another operation if the beta-HCG still stable or constant, or it's rising. So at that time, we may need to give her methotrexate or to have another surgery and offer her salpingectomy at that time. Okay, so give the common line and plus specific here for the salpingostomy. So when to offer the medical management? The medical management, the patient has to fulfill all the criteria, not only one criterion. No, the beta-HCG, I will write it here, just 1 second, here. Okay, the beta-HCG has to be less than 3,500. This is the best option, up to 5,000. So if all the criteria are there, so we can offer her the medical up to 5,000. And take care, it's written like that in the guideline. Number 2, regarding the size of the sac, it has to be less than 35 millimeter in all dimensions, like anterior and transverse, like this, or 3.5 centimeter. Usually they are using the millimeter. So 35 millimeter, and negative cardiac pulsations. The patient has to be pain-free, without pain. The patient not in pain, and she has to be stable. Blood pressure, pulse, and oxygen saturation, everything to be in the normal range. So no pain, no severe bleeding, the patient stable, the size the fetal cardiac pulsations to be negative and the beta HCG. If the patient fulfills all the criteria, so at that time, yes, you can offer her the medical management. If there is not, the patient fulfill all the criteria apart from one criterion, so no, please offer this patient surgery. For example, the beta HCG 2000 and the size of the sac 38 millimeter times 25 millimeters. What do you think about this patient? Now, this patient here, the size more than 35, so please don't offer her the medication. We need to offer her the surgery at that time. And the patient has to fulfill all the criteria. Please remember this in the exam. So that's all for today. After finishing the station, just give the patient information leaflet, admit her, and inform the consultant, the sleeping doctor, if the surgery will be the only option. If you want to repeat the scan or anything, involve as much subspecialties as you can. Refer her to a counselor if the patient has recurrent ectopic, because she will be affected, and show empathy to her through all the station or the consultation. Okay, thank you so much. That's all for today. And I will make another videos regarding the other topics very soon. Thank you so much. Assalamu alaikum wa rahmatullah.